every few years. The American Heart Association updates the ACLS Guidelines, and the 2025 version is here. This update takes a huge step toward improving survival after cardiac arrest. So what's new? What's changed? And what do nurses and clinicians need to know right now? Let's break it down. Let's start with the heart of ACLS, the algorithms. The adult cardiac arrest algorithm now emphasizes early defibrillation first for shockable rhythms like ventricular fibrillation and pulseless VT. Epinephrine is no longer given right away, it's now recommended after the initial defibrillation attempt failed. There's also a new bradycardia algorithm, a dedicated pathway for adults with a pulse and slow rhythm. It reminds us to first look for and correct the cause like hypoxia, ischemia, or drug effects before jumping into atropine, pacing, or dopamine and epinephrine drips. For those difficult calls about when to stop resuscitation, there's now a clearer termination of resuscitation rule. If there's no ROSC after 20 minutes of quality CPR and no reversible cause, it may be reasonable to stop based on clinical judgment. And this year, the guidelines add more emphasis on measuring CPR quality, using end-tidal CO2 and blood pressure monitoring to guide performance. When it comes to airway management, the focus is clear: ventilate effectively, but don't overdo it. During CPR, ventilate at 10 breaths per minute, just enough for visible chest rise. Video laryngoscopy is now recommended over direct laryngoscopy for most adult patients. It increases first-pass success and reduces interruptions in chest compressions. For patients with head or neck trauma, start with a jaw thrust, but switch to a head tilt chin lift if that doesn't work. And for foreign body airway obstruction, the updated guidance suggests 5 cycles of back blows followed by abdominal thrusts in unresponsive adults. Team coordination is everything here. Airway management should never interrupt compressions. Now let's talk medications, always a big topic in ACLS. Epinephrine stays at 1 milligram every 3 to 5 minutes, but timing is key. For shockable rhythms, it's now given only after defibrillation attempts fail, not before. Vasopressin? It's officially out, no advantage over epinephrine. There's also less emphasis on antiarrhythmics like amiodarone and lidocaine for refractory VF or pulseless VT. For atrial fibrillation or flutter, the first shock energy should be at least 200 joules for better success. And here's something new. Naloxone is highlighted for suspected opioid-related cardiac arrest. The AHA even encouraged public naloxone programs alongside AEDs, a strong step toward combating the opioid crisis. Post-cardiac arrest care is another major area of expansion. Maintain mean arterial pressure above 65 millimeters mercury to protect organ perfusion. Targeted temperature management or TTM is still in, but now with a minimum of 36 hours and a temperature range of 32 to 36 degrees Celsius. The guidelines now stress multimodal neuroprognostication using EEG imaging and biomarkers instead of relying on a single measure. If the cardiac arrest is from a suspected heart cause, coronary angiography should be considered before discharge. And this is big, a new focus on holistic recovery, assessing emotional distress, family impact, and long-term rehabilitation within the first year after arrest. The 2025 guidelines also strengthen the systems of care approach. Now, there's a unified chain of survival for both in-hospital and out-of-hospital cardiac arrests. And it starts with prevention. Hospitals are encouraged to use safety huddles and rapid response teams to identify high-risk patients early. For out-of-hospital arrests, the priority is high-quality on-scene resuscitation rather than rapid transport. Special situations get new guidance too. For pregnancy, perform resuscitative hysterotomy within 5 minutes if there's no ROSC. ECLS is now recommended for select patients with refractory asthma or hypothermia. And importantly, the AHA calls out social determinants of health, urging healthcare systems to close gaps in cardiac arrest outcomes. The new guidelines also expand on education and ethics. CPR training should now include feedback devices to improve compression quality and focus on reaching underserved communities. Ethically, the AHA promotes shared decision-making, family presence during CPR, and protecting clinicians from moral distress. It's a refreshing shift toward compassion and sustainability in critical care. The 2025 ACLS guidelines are not just about new algorithms. They're about better teamwork, smarter timing, and holistic care from arrest to recovery. If you're a nurse or provider, now's the time to review your algorithms. update your training, and be ready to save lives more effectively than ever. I'll be breaking down each of these updates in future videos, so make sure to like, subscribe. Thank you for watching and for supporting my channel.